All right, so to recap, because that wasn't recorded, your next exam is going to be in 2 weeks. It's going to cover just the lower extremity. Your final will be, well, that last week of class will be comprehensive, but primarily it's going to be topics 11 through 15. So spine, gait, posture, all that good stuff. You have your or not your biotech paper, but your kinematic analysis paper that's going to be due in week 14. Weeks 14 and 15, we are meeting via Zoom. You still only have to come to your designated day, so you don't need to show up for both days. If you want to, great. If not, that's okay. And then next Friday, the 19th, we don't have class, so hooray for that. So if you want to see the class live, you'll have to come to the Zoom session on Wednesday. So that would be Wednesday the 17th for all of you Friday people. All right, I think that about sums everything up, right? Okay, now getting into the knee here. All right, so this list here, the knee has only 3 bones, but what are all the bones that are going to interact with the knee? Femur, so your distal femur. Your patella. Tibia, so your proximal tibia. And then what else? There we go. So those are the 4 bones that are of importance to us. Now, the whole reason why it says 3 here is because the fibula is really not part of the knee joint proper. So fibula is non-weight bearing, doesn't actually really do any moving on its own, but it provides an attachment site for us. So fibula will be important as a lateral attachment site, especially for like our LCL. But when we talk about the knee itself, it is just your femur, your tibia, and your patella. So what kind of a joint is your knee joint?
It's a hinge joint, right?
It's a modified hinge joint. And it's modified because the knee also rotates. It doesn't rotate voluntarily, but we'll see here the knee does rotate. So hence the modified hinge joint. The only movements you can voluntarily do with the knee though are flexion extension. So you only voluntarily move the knee in one plane. So what axis does that move about? Sagittal plane, what axis?
Medial lateral.
Yes, very good. Now you have all these nice, bony landmarks and all that good stuff. I'm not so concerned that you know every bit here. What you do need to know is your tibial tuberosity. You should know the differences between your medial and lateral epicondyles. And then you want to know the I guess, surface structure of your femur and your tibia. So, well, it's kind of a poor drawing there for that. Your tibia is going to be concave, whereas your femur is going to be convex. So make sure you remember that. And here you can see a good reasoning for why the fibula is not part of the knee itself. And it's just because it's not actually, doesn't actually stay within the synovial capsule you need for the knee. Now, generally speaking, when you have a hinge joint, these should be pretty stable. The knee itself, even though there isn't, say, like a true bony connection between the femur and the tibia, is still pretty stable well on its own. I mean, you look at the elbow and you have, the, distal humerus has that nice olecranon notch to really just sit into, makes it, really stable to have your elbow there. With the knee, there's none of that. So you're just literally sticking two ends of bone together, and then you have all this nice soft tissue holding it in place. But it stays pretty well, pretty well stable. Your two biggest problems you're going to find with the knee are really with, say, I guess technically three problems. They're going to be overuse, traumatic injury, or like blunt force trauma, and then your pivot injuries. So if you can avoid those three, you're all good to go. When you look at the stability of the knee, I mean, you would think there's not much of it. I mean, the patella is free floating. You can all move your patella in all different directions, just as it is. You can kind of bend the knee side to side, even if you force it. But the kind of notches that the tibia creates and the convex nature of the femur make it so that it's almost like if you had that, the cup in the ball game. You know what I'm talking about? If you throw the ball into the cup, it's not really staying in there. I mean, if I just turned it over, it would fall out. But I can jiggle it around if I keep it upright and the ball stay in there. It'll move around, but it stays in there. That's kind of how the knee is. You have this where as long as you don't have any traumatic incidents occurring, you're pretty well stable on it. I mean, how many of you have just randomly been walking and just, I don't know, your knee collapses on you kind of thing for no other reason than it just did? Yes, it has. That's not good. Usually you think with, say, just general ambulation, your biggest worries are like rolling an ankle. So your ankle's much stronger than the knee, but it's also because it's much more susceptible to injury. Knee, for the most part, just doesn't like rotation. Rotational movements are not a friend of sagittal plane joints. Now, for your tibia fibula, like I said, you want to remember this here. So your tibial tuberosity. Remember that your fibula is always going to be lateral. Your tibia is always going to be medial. So your tibia forms your shin bone and your medial ankle, and then your fibula forms your lateral ankle. So fibula much more important when we talk about, say, the foot and ankle. And again, fibula is non-weight bearing. So even if you did, like, say, totally break it, you could theoretically walk around with no problem. I mean, it'll be really painful, but you could do it. All right, now with our patella itself, like I said, it's free floating, but why do we even have a patella other than being an attachment site for, your quads here? Like, what's even the purpose of having this? So you're going to need your patella to really flex the knee. That's the main thing with it. And this is also why you have tendons on both sides of the patella. Now, your patellar tendon is a little bit weird because it's not really a tendon, it's a ligament. And you don't think of ligaments as being something that's stretch. However, and this here is a bad picture, this is a better picture of it. You can see how the quadriceps tendon doesn't just end at the superior patella. It goes all the way down. So it kind of encapsulates the patellar tendon as well. It's similar to what we'll see with, like, say, the Achilles tendon, how both gastrocs and soleus form a common tendon there. Same kind of things happening here. So you need this to be free floating, essentially so that your quads don't rip off the bone every time you bend your knee, kind of thing. Whenever you flex your knee, your patella is going to move inferiorly. So it moves downward so that you have more clearance for the quads to be able to essentially stretch. If you were flexing and you didn't have this, you would essentially just snap your quadriceps tendons straight off whatever attachment site they were on. And then when you extend the knee, it moves back up superiorly. Because you have this nice groove here, so you have this nice groove here with the femur, it holds that patella pretty well in place. So the patella kind of sits a bit in a valley here to hold that somewhat secured. But just so you remember, patellar tendon is a continuation of the quadriceps tendon. If you ever see this labeled patellar ligament, it's the same thing. So your patellar tendon and or ligament is located inferiorly. So this goes from your inferior patella to the tibial tuberosity. Your quadriceps tendon located superiorly. Now, what happens if you dislocate this? It's weird to think of dislocating your patella because it's already free floating. So when you don't have any really joint attachment as is, it makes dislocation kind of a weird thing. Have any of you actually dislocated your knee? Good on you there. So you can see what happens here. Instead of this, and this isn't even looking all that good either, but instead of it having the patellar notch sitting right in the middle there of that, or of your, where your femur would be, you can see here how this is off to the side. The main thing that would give you a patellar dislocation is a rotational based movement. So usually it's going to be, say, a rotation and usually in a flexion pattern with the knee. So doing something like this is going to be problematic for the patella itself. Now, usually if you run into patellar issues in terms of like patellar stability, you're probably not having the healthiest of knees to begin with. But you'll see that for most everything that can go wrong with the knee, rotation is kind of the major culprit. The overwhelming majority of knee injuries you have are non-contact injuries. So meaning you do it on your own. When we talk about here in the next couple slides, your different ligaments with the knee, those get torn all the time. And primarily it's because you'll see people doing either a lateral based movement or a rotational based movement where they have a fixed foot. So arguably your foot placement and or foot mechanics are much more important to the knee itself than the knee actually managing itself or governing itself, if that kind of makes sense. The other major problem with this is there's not a whole lot to do if you dislocate your knee. You dislocate it, you obviously need to get that put back in place, which it will do pretty easily. But now, what's stopping it from just doing it again, kind of thing? It's not as though, like, say you've dislocated an elbow where your humerus is outside of that olecranon notch. You just put it back in, and okay, we're good to go. Yeah, you may have some structural damage around, but your stability comes back because you have that bony stability. Without having bony stability, it makes reductions of this a little bit more difficult, and that's why this is one of the highest rates of reoccurrence or highest injury reoccurrence you'll see. I believe the stat is roughly a 30% recurrence rate. So like if you dislocated a patella, you got, around about a 30% chance to do it again. Now, the actual ligaments we have here, you have 4: ACL, PCL, MCL, LCL. So your ACL and your PCL are both cruciate ligaments. Cruciate ligaments mean they form a cross. All of your major knee ligaments prevent tibial translation in that direction. So meaning that the ACL is going to prevent you from doing anterior translation of the tibia. PCL is going to prevent posterior translation, MCL medial translation, LCL lateral translation. All that means is that those 4 act as kind of a big 4-point kind of foundation to keep that knee stable. Your MCL, LCL pretty much stay in the same shape during their movements. The ACL and PCL are essentially like they're loose or they have a lot of laxity to them. Meaning if I fully flex my knee, my ACL will become loose, my PCL will become tight. If I extend the knee, the ACL becomes tight, PCL becomes loose. So it's not as though that, you're, say, taking something that, would be taut at one position and then it's just like floppy at another, but it has more laxity in it. So there's a lot more ability for some wiggle room within the knee so that you don't, say, rip your PCL if you just flex the knee kind of thing. Now, your LCL and MCL you can't really see because those are cut, but those are your collateral ligaments. Collateral just means you're going to avoid side-to-side movement. So ACL, PCL prevent sagittal plane movement. LCL, MCL prevent frontal plane movement. So again, what are we missing here? What movement are we missing? Transverse, yes. So you can see very quickly here why our knee doesn't like transverse plane movements. It doesn't have anything really safeguarding it from those. And then our meniscus. So the meniscus is your cartilage or the major cartilage you have located on the superior tibia there. And these are two kind of half moon shaped pieces of cartilage. This picture doesn't do them as much justice because what they kind of look like if you were viewing them from an anterior, or taking an anterior view is this. So even if this is your lateral meniscus, this is your medial meniscus. On the lateral sides or the outsides of both of your menisci, they're going to be the thickest. So they're kind of like almost a triangle wedge. As you get more medial with both of them, you get them to be, or they're a lot thinner. You have a lot more blood supply on the really on the outside. So the thicker portions have some vascular supply. The inner portions really don't at all. If you were to say tear your meniscus, there's only around about a 2 to 4% chance of having a spontaneous recovery, meaning it actually heals itself. Pretty much once you injure cartilage, you're kind of stuck with it. So again, meniscus does not like rotational movements. Usually with a isolated meniscus injury, you're doing a medial or internal rotation of your lower extremity on a fixed foot. You're not going to typically injure your LC or your lateral meniscus with that. So usually the medial meniscus is going to be the one injured from rotational movements. If you injure this, so usually you'll have an injury either to, say, the medial side, you'll get something either to the lateral side, or you can have something like rips it off from underneath. Usually what will happen, or what the first, I guess, kind of surgical intervention you would look at would be based on what your recovery needs are. So if you're like an athlete and you have a meniscus tear and you need to get back to playing real quick, what will just happen is if you get a tear, they'll go in and do a partial meniscectomy where they just cut that piece out. So if I had, here's my meniscus and I have a tear here, all they're going to do is cut that out and shave this down. So all that is just gone. Super easy, barely an inconvenience. Surgery takes like 20 minutes. You're back to walking in like 48 hours and you can return to play in like a week. What's the downside of that though? Yeah, it's gone forever. Gone forever, Aaron Hernandez. So when you actually get rid of cartilage, it's gone permanently. Doesn't regenerate. all your cartilage is going to break down over time. So essentially, if you have less cartilage there, you are bringing about arthritic changes a lot quicker. So, I mean, in the grand scheme of things, I mean, yeah, that's not great, but it could be a lot worse, I guess. Another thing that can happen is, let's say you get a tear here and you don't have an immediate need to return to a sport or something like that. Usually what will happen is you'll get a meniscus repair where this would be sutured back together with anchors. So those would stay in permanently there. It doesn't actually heal it because like I said, there's very low blood supply. So it's just going to essentially be like you have permanent stitches for that area. Protects it from ripping back open, but it's still only a temporary fix. If you get a repair, you're looking at being 4 weeks non-weight bearing and then an overall recovery time of like 4 to 6 months. Kind of seems like a whole heck of a lot. So first time I tore my meniscus was back in fall of 2008, and it was on like the posterior rim of my medial meniscus in my left knee. And what they did was they went in and did a couple anchors on it. And, in my haze that was, coming out of, anesthesia, I thought they said that I was good to start to go back and play like baseball again in 4 weeks. Not that I had to be non-weight bearing for 4 weeks. So I was walking on my knee, after a week or so. And it was like, man, this doesn't really feel that great. I don't know how I'm supposed to be, actually getting back to play here. Yeah. Turns out I wasn't supposed to be doing that at all. That surgery lasted me roughly, I think 4 years. Yeah. So it was fall 2011. I went back in and had to get it redone. So everything was fine after my recovery. I was playing baseball though here in that summer, and I went to steal second base. And as I turned, I felt it pop. It wasn't really painful or anything, but I kind of knew all right, yeah, that's what happened. When your meniscus tears, you typically have locking in the knee, meaning that you would go to say flex it, and then you wouldn't be able to extend it back out. And that's because usually the tear will cause a flap to come up, and that'll get caught on the bone there. And that makes it so that going into especially extension from flexion becomes very, very difficult. So yeah, they went in and then did the meniscectomy the second time around, and it's been pretty decent ever since. I mean, yeah, I do have some arthritic changes already to it, but aside from being able to tell, when the rain's coming, I haven't had too many negative effects with that. And the last thing would happen is you would have a meniscus transplant where you could get say a cadaver donor. And this would be if you had essentially a completely destroyed meniscus, you've had multiple knee surgeries kind of thing. You're too young for say a knee replacement. So that's what they would do, is a transplant. Those are kind of they have the highest risk of failure. But for a younger population that has really bad knees, it's your best option you have. All right, tibiofemoral joint, that's your actual knee joint itself. All right, so like we were talking about with your ligaments here, ACL or anterior cruciate ligament, this is going to provide us from going into anterior translation, or you're seeing this term here, hyperextension. This is much more important than the PCL because the PCL is going to prevent you from going into hyperflexion. Well, how many of you are going into hyperflexion of your knee every day? So essentially, if you were to, I can't even really do it, but how many of you are bending your knee excessively every day kind of thing? Versus, especially now, if you have like say a wet sidewalk and you take a poor step, you could slip. So slip your foot out and your knee actually goes back into that hyperextension. So hyperextension is much more of a concern than say like hyperflexion. So immediately that's why the ACL is much more important. Primarily, like I said, your injury mechanism here is going to be rotation of a fixed foot. So typically medial rotation, you'll see. If you do lateral rotation, which is less common, but a lateral rotation really wouldn't do a whole heck of a lot for, say, the ACL. I mean, yeah, if you like really were to like say have that foot planted and jerk the whole rest of your upper body around, yeah, it's probably going to tear everything up. But lateral rotation isn't all that terrible for it. It's going to be worse on your meniscus for lateral rotation than would be your ACL. But if this is torn, so you see the tear here, you don't salvage this. Like you take that straight out. That goes away. You look at like say your UCL in the elbow, and if you were to tear that, you keep those stubs in place because those are going to be your new anchor points for your donor ligament. For the ACL, all that's happening here is that when this gets torn, what you would do is you would rip this all out. You would drill holes into the femur and the tibia, and then you would put your donor tissue, stuff it up those holes and plug them in place. And then eventually new tissue kind of grows over it. So it becomes actually really secure. A reconstructed ACL actually has about a 2 to 4 times greater tensile strength than a perfectly healthy normal ACL. And it's usually because of the donor site that you're using. Now remember, tensile strength is your resistance to being pulled apart. Not really something you're going to be doing too often, I think, where say you would have to have your knee being resisted, being pulled apart from you. But it just gives you an idea that when you have that reconstructed, it becomes much stronger. You see here, this is where you're going to have that main incision site. Right here is where you would do your donor site. So for me, I had my patellar tendon harvested for an autograft. And essentially you take with the patellar tendon and you cut out this middle third of it and then suture the other two sides together. So you don't really change any of the integrity or the structural integrity of the patella or the patellar tendon, but it serves as a really good donor tissue to use. Rarely are you going to see your Achilles tendon be used. Patellar tendon is the preferred one because it's got the easiest kind of recovery time from it. Hamstring would be your second one, and usually what will happen is you would get, say, like if you had your right knee done, you would usually get like a left hamstring. But yeah, Achilles is going to be very rarely used, especially as an autograft, maybe as an allograft. So if you got like a cadaver donor. And there you can kind of see the bone plugs and how that works. All right, so do I even have it in here? Oh, So we've talked about Q angles before. Remember, your Q angle is just going to be the angle you have from your patella up the femur to the ASIS and how that is going to relate to your tibia. So your tibia is essentially a straight line up and down. Wherever your ASIS is, so remember your ASIS about belly button height, straight over till you feel that notch there. That's going to be offline with your tibia. However big that separation is, that's what your Q angle is. The bigger the Q angle, the less stable your knee is. So this is why, like, say, women have greater Q angles because they have wider set hips. Benefit for that is that you have a much easier time with childbirth. The bad portion of it is that it makes your knee inherently unstable. So women will have round about a 2 times greater chance of an ACL injury than males will. They also have a much greater chance of having a meniscus injury than males will. And it's just because the Q angle is bigger. The wider set that Q angle, the less stable the knee is. Ideally, you want the femur to sit straight on top of the tibia, but your Q angle says how much of that is deviated. The farther that gets deviated, the more difficult it is. Kind of the easiest way to, or the easiest stat to see that in practice is knee injuries in soccer players. If you do men versus women, female soccer players exponentially higher number of knee injuries than men will. And it's really all because their knees are less inherently stable due to having a wider Q angle. Now, if you're a female who has a smaller or a narrower Q angle, that's great in terms of knee stability. It may make, natural childbirth a little challenging, but at the same time, it's still going to be your knee health relative to your Q angle is going to be an independent or an individual feature. So if you are a female who has a narrower Q angle, you're going to have a more stable knee than someone that just has a wider Q angle. Conversely, if you're a male that had a wider Q angle, you would still have that same ACL or knee instability that you would see otherwise. All right, PCL does or prevents posterior translation. There we go. And this is the way that you would injure it. So Britney Spears, you are in a very compromising position here in terms of your PCL health. The major way you're going to injure the PCL is being really, if you have excessive trunk extension while having a flexed knee and a plantar flexed ankle. So essentially in the position she's in, if someone were to hit her straight on, like if I go spear tackle her now, that would most likely, put me in jail, but it would most likely injure her PCL if I were to do that. So really, the only times I can think of this actually happening would be if you were, say, like a football player and maybe you, fell and were in that position and then got hit. I mean, it's pretty rare to have the PCL be torn especially in a non-contact form. So really, that's kind of the only scenario I can think of that, practically speaking, would be something that would happen. So you have to be in the position she's in, and then essentially get knocked backwards, kind of thing. Shoot, I feel like if that happened to me, that my bigger worry would be like my spine. For the most part, though, unless you have like a completely torn PCL, you don't really do a whole lot for that. And again, it's just because of the movement it prevents isn't something we use all that much. Now, MCL, LCL prevent our medial and lateral translation of the tibia. Your MCL is much more susceptible to injury than the LCL because much more of the impact you would have or force you would have generating around the knee is going to be converted essentially to a medial placement. So what I mean by that is if I move laterally, I really don't generate any kind of force or any kind of stress on my LCL or my lateral collateral ligament. If I'm here and even I just straight up go to rotate or pivot and go to one side, all of my weight or all of the force gets put on the MCL. So even if you just sit there and you have your feet straight and then you just kind of bend one in, you're only going to get really feeling of stress on the medial side of the knee. You really can't get lateral stress on there. What you would essentially have to be doing is pushing outward and then going outward kind of thing, instead of you push outward to move inward because of Newton's third law. So LCL really stays pretty well guarded from most injuries because mechanically, most of the stress we have gets put medially on our knee. For the LCL itself, the only real way you're going to injure this is going to be from pretty much blunt force trauma. You usually don't see the LCL get compromised from non-contact. Now, again, if you have a particularly, bad injury, yeah, almost everything is going to get destroyed. But for the most part, your LCL stays pretty well intact for virtually everything. Now, this unhappy triad is a little bit misleading. So if you have a lateral blow to the knee, so meaning you get hit straight on the side of the knee's collapsing inward. Well, you can feel, if you do that, like I said, you'll feel definitely the stress that's on the medial knee. But if you get hit, you notice how the bones, so if this is my femur, this is my tibia, I get hit laterally, it's going to do this, right? So it's going to buckle outward. Well, the lateral epicondyle of the femur is going to dig into your lateral meniscus. So while this makes it seem like it's your medial meniscus that gets impacted, it's really the lateral meniscus that's problematic here. So MCL, ACL, lateral meniscus, those tend to go together if you get a lateral blow or take lateral impact on the knee. This won't happen if it's non-contact. So if I have a rotational based injury, now you're talking about MCL, ACL, and medial meniscus. Contact injury, lateral meniscus. Non-contact injury, medial meniscus. Now, it doesn't mean that happens every single time, but that's kind of your general rule there. All right, any questions on the ligaments there? All right, awesome. Have you ever heard of your knee plica before? Are any of you runners? Good on you there. Oh, you're a runner? I'm sorry. So your knee plica is it's not one specific landmark or one specific structure. It's really just where you have these different folds in your synovial capsule. So you have, ligaments going all around the knee that create your synovial capsule. Wherever you have those kind of folding points or those rollover points, that's where the plica essentially exists. most commonly you'll get, like, say, tears or inflammation in this when you are overusing the knee against impact. So that's why I say runners are typically going to be more susceptible to this because they have the highest amount of impact on their knees. It's something that it'll cause pain, but it won't really change any of the structural integrity of the knee. So I guess that's a good thing. I mean, granted, no one wants to ever be in pain, but at the same time, you know, if I have to have something wrong, I mean, I'm probably going to take this out of anything, to be honest. You have tons and tons of bursa sacs here. So we've talked about bursa sacs before. Remember that these are going to be your fluid-filled sacs that add additional shock support, lubrication, all that good stuff. They're much smaller in the knee than you have elsewhere, but there's also a ton more of them. All right, and that is all of the bony and non-muscular soft tissue that we have. So, feeling good about anatomy, hopefully. All right. Motions of the knee. Flexion extension. That was difficult. What is knee flexion going to be limited by? So what's going to prevent me from bending any farther than this? I mean, it's really the same thing as with elbow flexion too. So what's going to limit knee flexion?
To just the muscle.
What about the muscle?
What?
What about the muscle?
It's like in the way.
It's what?
Like in the way.
Yeah, essentially right there. So hamstring size and then quadriceps tightness. So just like with the elbow flexion limited by the size of your bicep. Once the forearm runs into the bicep, you can't bend the elbow anymore. You know, you're kind of stuck there. You would also secondarily be limited by the tightness in the triceps, although you're not going to be getting so tight of triceps there because you're not using it nearly as much as you would, like, say, your hamstrings or your quads. Same thing with the knee. Hamstring size is going to limit that because you would physically run into that. Now for me, I don't even make it that far. So I'm not even really touching my hamstrings with my, like, say, calves there. So tightness in the quads is going to do that as well. Where are you at in lab?
You just got done with our second practical.
Okay, so you've done the foot and ankle now. You should be now getting onto the spine. All right, so when you measure knee flexion, remember that you're measuring it from a, please Lord, don't break, but you're measuring it from a supine position where you have one leg out and you're going to bend one leg up, right? And why do you do it like that? Like, why wouldn't I flip over prone or even just stand upright? How much do you believe that what your teachers tell you? No, really, like, do you just take everything we say at face value? Like, yeah, this is true. Or you ever think, man, that doesn't sound right. Just kind of want to get a gauge here. So when you're measuring knee flexion, you do it from a supine position and by sliding the knee up so that you have to work against gravity. And then you also don't do it so that you don't need to activate, say, your opposite side muscles to stabilize you, or you don't have to activate, say, your really hamstrings to forcefully move the knee and hold it there. So you want to work against gravity, which is why you don't go prone. If I go prone, once I pass 90 degrees, I'm gravity assisted. So if I were prone and I flex my knee to 90 degrees, up to 90 degrees, I'm working against gravity. Over 90 degrees, I'm now working with gravity. So that puts you into what would be known as active assisted range of motion, which is going to be bigger than your regular active range of motion. So you're supine so that you have force against gravity, but you also are going to limit the amount of muscle activity, which would cause essentially a confounding variable there. So the more you know. All right, knee extension should be to 0 degrees. It is somewhat uncommon to have natural knee hyperextension, but not as uncommon as, say, having elbow hyperextension. So just because you have hyperextension doesn't mean that you have, poor knee health. It's just anatomically how you are made, kind of thing. So it does happen. I mean, ideally, you don't want to be going into hyperextension all the time. But if that's the way you are anatomically structured, I mean, that's kind of, the hand you're dealt there. Now, we talked about having rotation in the knee. And this is what makes it this modified hinge. Your knee only rotates when you get into flexion, with one exception, but we'll talk about that in a minute. So if I'm at 30 degrees of flexion, so this would be, full extension or 0 degrees of flexion. So 30 degrees is round about like right here. So at there, now I can start rotating my knee. I'm just going to do it at 90 because it's a lot easier. But if I actually move my lower leg in or out, I can actually get that knee to rotate. It's not something that you can really, it's very difficult to measure. So usually you would need, like, say, why am I spacing on the word? Not like an X-ray, but essentially you need some sort of, radiological device to actually be able to measure that. What's more practical for us in terms of knee flexion is this concept here of your screw home mechanism. There we go. This is where you have the involuntary rotational movement of the knee. Main muscle to remember with this is your popliteus. Maybe a picture somewhere. There we go. So this is the major muscle that we need to worry about here in terms of our rotation from the knee. So what's happening? To get myself into full extension, my knee has to screw and lock in place. And you can kind of feel it if you hold on to the knee. It's easier to feel it if you go, like, say, just below your patella and hold on to, try to hold on to either side of the tibia. You'll be able to feel that rotational movement. But when you go from partial flexion into full extension, you have to externally rotate the knee. So the tibia externally rotates to lock in place there. This is why when you do any kind of load-bearing exercise for your legs, you're always told not to lock out your knees. And it's because of that screw home mechanism. Because when you lock them out, you are quite literally locking that knee in place. So when that tibia rotates, it's kind of like a, like one of those screws you would get at IKEA, where they're like the big circle things and you just kind of twist them in once and they lock into their hole. I was just shopping at IKEA, so that's why. But then when I go from full extension to flexion, now I have to rotate internally to unlock the knee. So that's where you are going to have really the primary rotational based movements with the knee. Now, in the two questions here, the tibia laterally rotates on the femur in the what chain? So is that a closed or open chain? Huh?
We can be open.
Why?
I'm kind of just taking a guess.
Well, you're not wrong.
I would think because you're moving laterally, moving outside.
Not so much of the direction you're moving, but what is moving. So remember, to have a closed chain movement, your distal attachment point needs to be fixed. So for example, if I go to stand up, that is a closed chain movement because my feet are fixed to the ground and that's my load bearing point. Because my feet don't move, it's closed chain. If my feet were to move and I were doing a leg exercise, so let's say I'm doing my knee extension machine. Open chain because my distal point of attachment or my load bearing side, which would be where the weights are down here, that is open or that's not attached. I get to keep moving this. Kind of like if I'm doing a biceps curl or I'm doing virtually any upper body exercise, all open chain because my attachment site or my hands are moving with the weight, open chain. Because the tibia is moving, this means that you can't have a fixed foot. So because the tibia moves, it means the foot or the lower leg moves. When the lower leg moves, it's not fixed. It's not fixed, it has to be an open chain. When we have the femur internally rotate to get us into flexion, that is going to typically be your closed chain movement because tibia is fixed, femur's moving. See how that works? All right, so that is your screw home mechanism there. And then convex concave. All right, so your convex concave rule, does this describe arthro or osteokinematic movement?
Arthur,
Why?
because it's like a gliding, rolling,
Spinning.
spinning.
Yes. So when you describe roll, slide, glide, spin, you are describing arthrokinematic or joint surface movement or motion. Remember, arthrokinematics occurs at the joint surface. It's not something we see. Osteokinematics is the visual representation you see of the actual movement of the joint. Okay, so remember I told you earlier how your femur is convex, and then your tibia is concave. That is where you have this convex concave rule. So that here is femur, that here is tibia, this here is femur, this here is tibia. If you just look at this from this picture, it'll confuse you because it's essentially saying in this picture here that your tibia is on top of your femur, which, you know, it isn't. But again, this goes back to how our foot is positioned. If our foot is fixed, this means that the lower leg doesn't move. If our foot is off the ground or not fixed, it means our upper leg doesn't move. Easiest way to think about it is standing up. So if I go from sitting to standing, what is the position of my feet? Are they fixed or are they movable? They're fixed, right. So because my feet are fixed, my tibia does not move. This means to stand up, the only bone that moves is my femur. Because the femur moves, that is your convex movement. So the femur itself is moving on top of the tibia. If I sit down and then I kick my legs out, what's the position of my feet? Are they fixed or are they movable? Movable, yes, they are off the ground. Because they're off the ground, my tibia is moving. My femur stays fixed. So when your feet are off the ground and you have lower leg movement, that is going to be your concave movement. With me so far? Now, what you have to then be able to visualize is the roll and slide of really the tibia and or femur. When you have this convex movement, the roll and the slide happens in opposite directions. So convex is going to be closed chain. So when I stand up, femur is only moving. Well, when I stand up, the femur is going to have to rotate or roll anteriorly, but then it has to slide posteriorly. If it didn't slide, I would stand up and my femur would be in front of the tibia. So it has to roll forward and then slide backward. So convex movement, your roll and your slide go opposite. Anterior roll, posterior slide. Concave movement goes in the same direction. So my roll and slide are going to go in the same direction here. When I kick my leg out, it is an open chain movement, and I'm going to roll posteriorly, and I'm going to slide posteriorly. See how that works? So open chain movement for the knee is going to be a concave motion. I'm going to both roll and slide posteriorly. Convex is closed. Whoops. Convex is closed chain. I'm going to be moving the femur only, so feet planted on the ground. The femur is going to roll anteriorly and then slide posteriorly. So opposites. If you can get that concept, that's probably the most difficult. That along with screw home mechanism are probably the two most difficult concepts to get with the knee. So as long as you got those, I mean, pretty much got everything mastered. All right. And then in terms of our actual movements here, we didn't talk about knee external rotation, but primarily you're going to see, here we go. Your semi-muscles are going to do, sorry. So internal rotation is going to be with your semimembranosus, semitendinosus. So that's going to allow you to go from full knee extension into knee flexion. External rotation done by the popliteus, that allows us to go from knee flexion into full knee extension, or a better way to put it would be terminal knee extension. If you couldn't extend your knee greater than 10 degrees, meaning that if I couldn't achieve like a 0-degree extension, that I could only get to roughly like 10 degrees of extension, I would use very little, if any, of popliteus. So anyone that has really an inability to fully extend the knee to within 10 degrees of 0 is going to have a really kind of a weakened or kind of deteriorated popliteus muscle. Now, obviously, your semimembranosus and semitendinosus are going to do a lot more than just knee flexion. But as long as you're able to flex the knee, those are going to be, for the most part, fine. But again, remember that anytime you pass over a joint with a muscle, you're going to move that joint in some capacity. So quads and hamstrings, even though those are both going to originate on the pelvis, they're going to insert on or around the knee. So they are the ones that are your primary knee sagittal plane movers. Quads, your primary knee primary knee extensors. Hamstring, primary knee flexors. Your semimembranosus tendinosus, going to be your knee internal rotators, and then your popliteus, knee external rotator. Internal external rotation can reach up to about 30 degrees. Knee extension should be at 0. Knee flexion should be around about 120 to 140. All right, what kind of questions do you all have on this so far? All right, rather than go into all the muscles and movements with them right now, I think we will stop there. So I'll let you out a couple minutes early here. Hopefully that's all right with all of you. But again, for this week, make sure you just get that BLA completed. Next week, we will be finishing up the knee and then getting into the foot and ankle. And then in 2 weeks' time, you'll have your third exam, again, just over the lower extremity. All right, so if you all don't have any other questions, you guys are all good to go. So thank you all for getting through all this with me. And then I will stick around until you all leave, and then I will see you all hopefully next Friday.